Well, good evening, ladies and gentlemen, and it's my privilege and pleasure to welcome you here to the Royal Society of Medicine for the second Sir Naim Dangoor Lecture, How Digital Innovation Can Improve Healthcare. I want to start by expressing a particular welcome to the Dangoor family, David, Michael, Robert, and Ellie and their partners, and all of their family who are here tonight. I also want to specifically welcome some other people, Carice Ellison, who's been such a benefactor to the RSM over many years, together with Brian Whittle, who's been a long-standing supporter here. I'd like to welcome staff and students from the Westminster Academy, an academy that's supported by the Dangoor Foundation, and which I just heard from David Dangoor earlier has achieved 19th place nationally in the sixth form rankings, which is a fantastic achievement in the last few years. And we're also pleased to welcome representation from the Patients Association for this evening's lecture. In a minute, David Dangoor will introduce our two guest speakers, Lord Darzi of Denham and Mr. Mustafa Suleyman. So I will not say any more about them, except to point out that Lord Darzi has, I think, the singular distinction of having resuscitated one of his fellow peers in the House of Lords. So if any of you are not feeling so well, here's the man to help out. You can say it's a heart surgeon telling you that as well. Anyway, this evening's lecture is named in honor of Sir Naim Dangoor, who sadly passed away last year at the age of 101. He was born in Baghdad in 1914 when Iraq was under Ottoman rule, and he subsequently traveled to London to study engineering, and on his return to Iraq went into business. He built up a diverse portfolio of activities, including property development and letting, a match and furniture factory, and he won the first contract to bottle Coca-Cola in Iraq, which is also particularly apposite as the headquarters of Coca-Cola are right next door to us at the RSM. In 1947, he married Renee Dangoor, and they had 4 children. Following the birth of Israel and Arab nationalism, things became increasingly difficult in Iraq, and Naim Dangoor moved his family to Britain. And for a few years, he traveled between Britain and Iraq, but subsequently events became very difficult in Iraq, and he permanently relocated to Britain. Settling in London, he vowed that if he made another fortune in the wonderful country that had taken him in, he would plough his gains back into philanthropic causes. So he set up a commercial property business, which his sons joined him in, and it soon began to thrive. And with that success, he was soon able to make good on his promises. He started to give back to many organizations and charities focusing on education and health. In 2014, he made the largest philanthropic gift to the Royal Society of Medicine, and some of you will have seen the lecture theatres that is named after him as you came into the entrance hall this evening. But he also donated to the Francis Crick Institute and to Cancer Research UK. He funded over 1,000 scholarships for students with no family history of tertiary education, and gave £4 million for students from low-income backgrounds to study STM subjects. So he had a massive philanthropic donation to many, many people in many, many different walks of life. And these, as I've indicated earlier, include the Westminster Academy in London, whose pupils hail from over 60 countries. And as I said, we're particularly welcome to many of them this evening. So Naim was made OBE in 2006, CBE in 2012, and in June 2015 became the second oldest person to receive a knighthood. He had 7 grandchildren and 2 great-grandchildren who survive him in addition to his 4 sons. The theme of tonight's talk is medical innovations, and many of you will know that the RSM has a flourishing program in medical innovations, which has now extended to over 180 presentations. Many of our speakers have traveled from long distances to be here to speak about their ideas which will benefit patients. Others have traveled from not such large distances, including Hammersmith and King's Cross. In April this year, we'll be hosting our 12th summit with 13 speakers, a large faculty from around the world, but interestingly including a 15-year-old from Britain who won an innovation prize for research into the early diagnosis of Alzheimer's. So here at the RSM, we're delighted to be able to encourage youthful enterprise and energy and innovation. Over 250 people have already registered to attend the April Summit, and if any of you still in the audience who haven't registered wish to attend, I would suggest you register fairly soon, otherwise you may have difficulty in getting in. So I'm going to invite David Dangoor to introduce our speakers. Lord Darzi will be speaking first, followed by Mustafa Suleyman. There will be an opportunity for questions and discussions, but I would ask you when we come to question time to please keep your questions brief and to the point, otherwise I shall have to shut you up. The closing remarks and vote of thanks will be given by one of our RSM members and also junior doctor, Dr. Cozy McGretton. So welcome to the RSM, and David, can I invite you to come up and say a few words?
Good evening. Professor Lord Darzi of Denham holds the Paul Hamlin Chair of Surgery at Imperial College London, the Royal Marsden Hospital, and the Institute of Cancer Research. He is Director of the Institute of Global Health Innovation at Imperial College and Chair of Imperial College Health Partners. He is also an honorary consultant surgeon at Imperial College Hospital NHS Trust. Research by Professor Darzi is directed towards achieving best surgical practice through innovation in surgery and enhancing patient safety and the quality of healthcare. His contribution within these research fields has been outstanding, publishing over 800 peer-reviewed research papers to date. In recognition of his achievements in the research and development of surgical technologies, Professor Darzi has been elected as an honorary fellow of the Royal Academy of Engineering, a fellow of the Academy of Medical Sciences, and in 2013 was elected as a fellow of the Royal Society. He was knighted for his services in medicine and surgery in 2002. In 2007, he was elevated to the United Kingdom's House of Lords and appointed Parliamentary Under-Secretary of State at the Department of Health. Upon relinquishing this role within central government in 2009, Professor Darzi sat as the United Kingdom's Global Ambassador for Health and Life Sciences until March 2013. During his appointment and beyond, Professor Darzi has developed his status as a leading voice in the field of global health policy and innovation. Professor Darzi was appointed and remains a member of Her Majesty's Privy Council since June 2009. In this year's New Year's Honours, it was announced that he would be admitted to the Order of Merit. This award is in the personal gift of the Queen and is limited to 24 living recipients. Like my late father, Sir Naim Dangoor, Lord Darzi was born in Baghdad, and he confided in me just now that he went to the same school as my father and then moved to the school that I went to in Baghdad. And he has given much to this country. So I am particularly pleased, delighted that he has agreed to give this year's Sir Naim Dangoor Lecture. Mr. Mustafa Suleyman, who will follow Lord Darzi, is co-founder and chief product officer of DeepMind Technologies, a leading artificial intelligence company backed by the Founders Fund, Li Ka-shing, Elon Musk, and David Bunderman, among others. The company was bought by Google in 2014 in their largest European acquisition to date. He is now head of applied AI at Google DeepMind, responsible for integrating the company's technology across a wide range of Google products. At 19, he dropped out of Oxford University to help set up a telephone counseling service, building it to become one of the largest mental health support services of its kind in the UK. He then worked as a policy officer for the then Mayor of London, Ken Livingstone. Mustafa went on to help start Rios Partners, a boutique consultancy with 8 offices across 4 continents, specializing in designing and facilitating large-scale, multi-stakeholder change labs aimed at navigating complex problems. As a skilled negotiator and facilitator, Mustafa has worked all over the world for a wide range of clients, such as the UN, the Dutch government, and WWF. May I please introduce Lord Darzi?
Mr. President, David, thank you very much for that warm introduction. I have the challenge now to make the case, or at least show you that the school that I went to wasn't as good as 1914, but we did go to the same school, and it's an amazing coincidence to see that. And subsequently, you probably will also see when we share the platform for Mustafa that I haven't yet cracked the artificial intelligence side. So I'm going to use whatever I have up there. So the whole purpose of today is to share with you innovations in patient safety. Patient safety is something that's been very close to my heart, and I know many of my clinical colleagues here will know not just something about it, but is the type of thing that always stresses any clinician involved in patient care, let alone the patients that we have the privilege of treating. I'm also very pleased that I'm co-presenting this with Mustafa, who I've got to know over the last 2 or 3 months, an amazing person in terms of his intellect, and has also an interest in what we're doing. So before I start, I think it's worthwhile remembering the late Sir Naim, who you've heard a lot about him from the President, but also acknowledge the tremendous contributions he's made in philanthropy, in research and life sciences. We're all very grateful for him and his family for their generosity in supporting research and development. So moving into the arena of patient safety, most of us will know who Florence Nightingale is and the contribution she made, and she survives in our imagination as the most inspired nurse this country produced. But the lady with the lamp, some of you may know this, was also a pioneering and a passionate statistician. Following the International Statistic Congress, which was in London in 1860, and I wouldn't say that far away from this building, the London hospitals decided for the first time ever to publish the inpatient mortality rates over a period of 5 years. And this publication by William Guy from King's College looked at the average, as you can see on the right-hand side, over a period of 5 years. I think David Sloman is not here, but his chair is here. Dominic, he'll be delighted to see that nearly a century ago or more, the Royal Free was the best performing hospital. And I have no doubt it is still the same. Now, within that a century, or within that century later, we've all seen the tremendous contributions that science and technology and innovation has made to our life expectancy. Now, who would have predicted in the last 100 years that life expectancy would be doubled? You tell me any other discipline, any other sector that has such an impact on mankind. In the first part of that century, most of these interventions were public health interventions. In the latter part of that century, some of the technological innovations, some of which are up there, MRI, CT scans. And what's unique about that last century, 40% of the major disruptive technologies came from the UK, from Great Britain. That's an amazing legacy to have. So the investment that the Dangoor family have made in the life sciences industry will show its fruits. Despite the statistical publications that we've seen earlier, despite the life expectancy being doubled, we are still challenged, those of us working in healthcare, those of us in this room who have received care from our healthcare system, have a major challenge facing us, and that is patient safety. Most of you will remember when all of that started in Bristol, and the cardiac inquiry there, and more recently, the mid-staff inquiry. And you don't have to go far. William Mead, what it was 3 or 4 weeks ago, and his tragic death from a misdiagnosis of sepsis. If you look at the scale of the harm, it's about 10%, 1 in 10 patients who go to a hospital to get better, they leave that hospital with an injury. 1 of 3 of these injuries are serious enough, and more than 50% of that harm is preventable. If you look at the mortality rates, the predictions now, this is a publication from Helen Hogan from the London School of Hygiene and Tropical Medicine in 2012, which was updated recently with the Bruce Keogh review, more than 10,000 deaths in hospital settings in the United Kingdom are preventable. And the most common causes are poor monitoring, diagnostic errors, and medication errors. The famous saying, error is human. And we've been looking at this. We are very, very fortunate to be funded by the National Institute of Health Research, and I happen to have the privilege of leading the Patient Safety Translational Research Center. And we've been looking at healthcare and why has it become so risky, despite all the technological advances that I've showed you earlier. Firstly, healthcare delivery has become a team sport. We all know that, and we all respect that. But coordination of it, members of the same team, let alone coordinating number of different teams around the needs of fairly complex patients with multiple morbidities, has become a challenge. At the same time, multiple complex interventions, which could be on different sites with centralization and decentralization drivers in the health system, and the fragmentation of healthcare. One of the insightful things that patients told me when I had the privilege of leading a major review of the NHS is that if you see the pathway of care from a patient's perspective, it's very fragmented. We create these boundaries because we can't cope with it. My boundary is the surgical patient who's under my care the day they arrive and the day they leave. But the patient sees the whole pathway of care. So the fragmentation, all of these different factors, where technology has enhanced our life, but in many ways, we've created a system that is too complex and too dangerous in many ways. In today's talk, I'm going to focus on 2 very important core safety challenges that I think are facing us today, and in the last 2 or 3 years, it is becoming more and more acute. Firstly, how do we detect a patient is deteriorating in the hospital setting? This patient and their family thinks that they are in a safety zone, they are in a hospital. But the challenge we've had is how do we actually monitor the patients and to ensure that we pick up their deterioration and as a result of that intervene at an earlier stage rather than when it's too late. The data out there is very clear, including NICE, and I could see the previous chair of NICE here. The National Institute of Health and Clinical Excellence have recognized that substantial problems are there in identifying a deteriorating patient. And you may say why that happens to be the case. We actually have a huge data that we measure in a hospital setting. I don't know if the patients or members of the public, but certainly most of the clinicians here are fully aware on the volume of data we collect. And this is 2016. We still have them on these flimsy pieces of paper. Half the time, it's not even beside the bed, measuring all sorts of things, physiological data, biochemical data, including stool charts, urinary output, so on and so forth. The problem with this type of technology is a subtle change in any way. It's rarely recognized until such time as there is an acute drop in the blood pressure or a real increase in the pulse that may alert the nurse who might be available to detect that. And once that detection happens, obviously she or he has to inform someone who knows how to deal and how to manage that case. The second issue in the pathway of care of someone who's deteriorated is to intervene. Start, firstly, by getting the right person to see the right patient in the right time. You might think that is very easy, but in actual fact, in about half the patients, that escalation of care, if you go back retrospectively and look at that information, is delayed. And this was the publication of a member of our team, a PhD student with us, Max Johnson, who looked at a systematic review. And may I just say, this is not a unique problem in the United Kingdom. It is, as you can see, the US, Australia, and Japan, about a 20 to 50% delays in identifying these patients. And the box on the right-hand side shows you the correlation between the delay in picking that up and its impact on morbidity and mortality. Now, let me tell you how we communicate when someone is deteriorating. What's the first line of communication to someone to come at least deal with that emergency in a ward environment? If you go up to one, and this picture was taken from one of our wards yesterday, because we wanted a picture to show you what the technology we're currently using. The bleep system is about 50 years old. I'm sure some of you here will swear by these, but I'm just about to show you something better. That is what the house officer or the senior officer will wear. And at the same time, on the right-hand side, one of the commonest handover notes that is given between two doctors leaving a shift and handing over the notes to the person taking on the shift. And what's interesting, something else we really, as we studied this, on average, a junior doctor on a shift of 8 hours will receive about 100 different calls or jobs. The St. Mary's Hospital, the acute medical service, just the acute medical service, forget about surgery and all the other disciplines, they receive about 1,000 jobs and tasks a day. You go and ask anyone, what are these tasks? No one has a record of them. You get a bleep, this patient needs some bloods done, this patient needs a catheter done, this patient needs that. And that is the type of messaging that the individual receives, and they haven't finished that job. They write this sheet on the right-hand side to hand over the patient. So it's a fairly cumbersome thing. The nurse goes up to the phone after she detects a deteriorating patient, calls the operator will page the doctor, and this poor doctor is receiving a significant number of messages on his pager, and he or she has to make a decision where to go, and without any information in terms of prioritizing the patient that they need to see next. So the main core and the hypothesis of our work has been, how do we have a better detection systems, and how do we have better systems to intervene? The first one is early warning signs and how we can pick those signs of deterioration. And the only way we could do this is what we are currently using in all aspects of our life, whether it's shopping, banking, and that is the digital technologies that are available to us, and also a better use of data. I famously said in 2008, you can only improve things if you measure them. And that's the reason I remember working with many colleagues in this room. I remember giving a talk in which we talked about really having quality accounts and measuring quality, because if you can measure it, you can actually improve it. Now, other sectors are very smart. They've done this before. Just look at the number of serious and fatal accidents, the mortality from road traffic accidents over a period of 30 years. Now, how come they could achieve this? And all the investments we have in the life sciences, all the technological advances that I showed you earlier, could not be translated in improving patient safety in a hospital environment. And how did they do it in reducing road traffic accident? A fairly ranging technologies over 30 years, from seat belts to brake pads, and finally, the last technology, I don't have a very new car, but I've seen and I've driven one, which is what they call the assist driving technology, when in actual fact, it alarms you as a driver. It tickles you, I think, when it drives in the seat, that you're about to hit the curb or you're about to hit the car beside you. I'd love to have one of these, which might actually push me to recognize someone who's deteriorating. So most of our effort has been, how do you actually translate technology in enhancing patient safety? Information technology is the way to do it, but the current systems we have are cumbersome. They've taken years to install, and I don't want to go to the fiascos of the cost of the information technology systems that were installed within the NHS. I'm going to share with you a couple of slides, the end user view. Ultimately, I know this because I'm a doctor. Doctors only use technology if it's going to make their life easy. Look at some of the end user views that we've captured. It took 1 hour to teach a doctor how to prescribe paracetamol through the IT system. I don't think I'm stupid, but it could be more complicated, and so on and so forth. In actual fact, you don't have to ask the doctors and the nurses who are using these systems. Ask the regulator, CQC. Just some of the reports from their inspections. Data quality issues have also been highlighted. Of total of 460 records that could have been completed, 25 were valid, 280 were invalid, and 155 were missing. So despite the investment, if you don't have an intuitive system that the doctor or the nurse feels that it's helping them to deliver a better care to their patients, they're not going to engage with these tools. And at the end of the day, they become an administrative tools in which the finance director could calculate how many patients came in the door, how long did they stay there, rather than really looking at the huge potential of information technology, which has transformed everything else in our life, but not necessarily in healthcare. So we've been looking at how could we engage clinicians at the front line, identifying the gaps, and using more simplified technologies in developing these technologies. And this whole idea started with some collaboration. As you know, I come from Imperial, which is probably the best endowed institution when it comes to the power of engineering, science, software, writing. And beside Imperial, there's another wonderful organization called the Royal College of Arts. I don't know how many of you have visited that. But design was something else that I recognized as I matured will have quite an impact on delivery of healthcare. So this is the Helix Center, which is a joint venture between Imperial College and the Royal College of Arts. So this is the pod, this was funded by HEFSI. It's actually in the middle of the hospital, and the reason we put it in this wonderful piéton between the medical school and the old building is because that was the best way of really getting that staff coming into there and really coming up with their clinical problems, and at the same time patients who came in there really sharing some of the challenges in terms of the wards they were in. And we have a number of designers there. You can see Maya, who is in there, and a number of others there who essentially designers, engineers, software writers, who really try to identify these different gaps and develop the different apps, as you can see here, which having an impact on a number of different pathways of care. But the one that has been very unique, which has really been championed by one of our lecturer, Dominic King, who's there somewhere, there he is a lecturer in surgery. Back to some of the challenges that I was telling you earlier, how could we capture this information better? How could we develop an early warning systems in which a doctor could prioritize some of the tasks that they've been given and then intervene and start the treatment? So Hark is essentially bringing all of these different inputs, blood test, physiological monitoring, and combine those together and really deliver it then to the individual clinician looking after a patient in a ward environment or even in a primary care environment. So I'm just going to go through some of the description of it. This is a task being ordered, a very simple task. You can order it within 30 seconds. And I think what's unique about this, the person who's ordering that task will actually identify the person of the right seniority in ordering that task. The task is created, and then the task is received by the individual who needs to who needs to respond and act on that command. The prioritization are significantly easier. obviously with certain algorithms. You can see here the actual doctor will have a priority of different jobs, so at least who could go and see the patient who's sickest in the shortest period of time, rather than having a list in front of them and trying to make a judgment call without the necessary information. So if this is some of the work which was the output of evaluating this at Imperial College NHS Trust, mainly on the St Mary's site. You can see from a functional perspective, there were 11 supplementary communication functions with the device, information transfer, 22 out of the 24 critical factors were better communicated using the app and digital app. And finally, the response time, as you can see, had significantly improved by about 37% less time taken to respond to a task request. So we've developed this. You know, it's amazing because you go around and you think NHS is a basket case, but the NHS is not. You can actually create innovations in the NHS. NHS should be leading innovations. We've reached a stage after the development that Dominic and a number of other colleagues in the department recognized that really to scale this up and trial it even within the large Imperial College Trust on the 3 sites, we need some help. And we were delighted to meet Mustafa and his colleagues, and DeepMind, you know, I was there in the office yesterday, some of the smartest people I've come across, and the idea of developing a partnership, which has already worked extremely well at the Royal Free, as you may know, and really taking this up and scaling this up. And I know the NHS Trust leadership are very excited about this, and they've been absolutely brilliant in facilitating this innovation coming through. So I think I want to share with you an example, a very simple, what I call a frugal innovation that could have a huge impact in improving communication, identifying sick patients, preventing deterioration, and escalating care. And thanks to the group, which is this is the launch of our Patient Safety and Translational Research Centre nearly 3 years ago in the House of Lords, and that's Dame Sally Davis there, who is the director of NIHR. And I'd like to thank, finally, obviously, Imperial College for facilitating this, the Trust, who've really, with open arms, have embraced this innovation, NIHR, but also Imperial innovation. So on that note, I'm going to now hand over to the smart guy who's going to tell you how we're going to take this over and really have an impact on patients and their safety. Thank you.
Thank you very much. So thank you, Ara, for a wonderful talk and for framing, I think, the patient safety challenge that we have taken on. So my name is Mustafa. I'm one of the co-founders of Google DeepMind. Before I talk to you about the patient safety challenges, I want to start with a little bit of a background on DeepMind, who we are and what's really motivating us. I'd like to put it to you today that one of the defining characteristics of the modern age, I believe, is that we are overwhelmed by the complexity of the systems that we've created. All around us, we have the smartest experts, people who've trained for decades and decades, struggling to respond to some of our most complex problems, whether they be climate change, or building sustainable food systems of fair production, or whether it's taming our complex financial markets. In some sense, what we're struggling to cope with is to make sense of these vast streams of data, these high-dimensional, temporal, abstract streams of data that are coming in from all of the sensors that we've created around us that somehow describe the nature and structure of the world today. 5.5 years ago, I founded DeepMind with 2 of my colleagues, and in some sense, it was a response to exactly this problem. We recognized that we were overwhelmed by complexity and overwhelmed by information. And we posited that over the coming decades, the real benefits and innovations and productivity gains that will come in our civilization will be those that we derive from better understanding the vast streams of data that we're creating around us. If we could somehow learn the nature and structure of this data well enough to be able to predict its course over time, then that would better help us to intervene in this complex world around us. And at its heart, DeepMind is very much a British research organization. So we have something like 250 staff, 180 of the very best AI researchers, postdocs, PhDs, and professors in the world. Over the last 12 months, we've been lucky enough to score 2 Nature front covers. First, this time last year, with a Nature front cover for our Atari DQN work, where we trained an algorithm to learn to play multiple Atari games, old school Atari games from the 80s, purely from raw pixel inputs. Just in the last couple of weeks, we've announced that we've become the first ever system, AlphaGo, to beat a human professional at the game of Go. In the next couple of weeks, we're actually going to be playing the world champion in Korea for $1 million in a 5-day live match. And what we've tried to create at DeepMind is a kind of hybrid organization. We've tried to bring the very best that a focus on long-term research has to bear and learn all of the best bits from academia and bring those into the heart of our organization, while simultaneously combining those things with the pace and the scale and the agility and dynamism that we get from working as a company at scale. And all the while thinking, what can we do that would be meaningful? What really is our purpose? What are we really focused on? And that's where DeepMind has social impact at the very heart of our core mission. In some sense, I think this makes us uniquely placed to work within the NHS. We have the resources and technical expertise of one of the best technology companies in the world. And yet we also have the agility of a startup, structured as we are in these small cells that have a great deal of autonomy and can work really, really fast, but all the while driven by the kind of meaning and purpose of a social impact organization. So let me start with what I think is a very brief diagnosis on why health tech has underdelivered over the last couple of decades. In some sense, it's sort of struggled to do what nurses and doctors want, what they know that they need. One of those reasons, I think, is because it's consistently delivered, I guess, what you could call a kind of one-size-fits-all or top-down system, rather than something which has been co-designed in collaboration with clinicians directly. Typically, the characteristic of these deployments is that they've been very large-scale step-change introductions, where there's really only one version. You buy a product off the shelf, you deploy it to a 1,000-person organization, and it updates and improves very slowly. And this isn't the characteristic of the sorts of apps that you'll be using on your phone every day and that you're also familiar with. The other thing that I think has really slowed things down is that typically the companies have stuck with proprietary standards, which tend to create closed systems. And that means that they've defined their own database schemas. They've defined and hand-curated data in a particular way, which is the reason why a lot of your technology systems don't talk to one another. And I think that's a really big mistake that prevents both academic research, clinical epidemiologists, and also startups or doctor hackers who have a great idea from getting access to that data and being able to experiment and deploy their own prototype app. We've already covered some of the common complaints, but I'm sure you'll be all familiar with the questions of why on earth are we using pagers in 2016? Where else in the world do we have pagers in production in such an important environment? There aren't enough desktop computers on a ward. I've heard this over and over again in the last 9 months, and it sort of amazes me. When you do find one, the battery's probably died, or the smart card reader doesn't work, or there's a key missing in the keyboard, and there's some really fundamental infrastructure that doesn't seem to be quite right. Quite remarkably, I've actually experienced faxes in operation. I genuinely didn't know that these things were still in use until I started collaborating with my friends at the Royal Free and at Imperial. I've also heard the complaint that we wait for hours, sometimes even days, for X-rays to be transferred between hospitals. Clearly, this is something that should be digitized. Now look, this is obviously an incredibly intimidating arena for technologists. In some sense, the history of the last 2 or 3 decades represents a kind of daunting prospect. This hasn't been a particularly successful place for technologies to work. But I want to argue that if the NHS needs new technology, as Ara has so rightly put, then the onus is really on us. Technology needs to find a new way to work with the NHS. Let me try and present you a few of those ideas today. This is actually incredibly simple. ask the question, what does the user need? And when you've asked that question, ask it again and again and again. And let that be the guiding light shaping everything that you do as a technologist. Doctors and nurses already know what the problems are. They work on the front line day in, day out. They're very smart people, they're very creative, and often they even know what the solutions are. What I've heard is that doctors and nurses have been demanding, 1, mobile first. Why can't I have data in my hand at the right time? I need the right piece of information right in my pocket so that I can make the appropriate diagnosis or take the appropriate intervention. This needs to be shareable across teams. Why can't I communicate this information and my own views on the current state of the condition of my patient to my colleagues? And this should be super easy to learn to use. No one's ever had to go on a training course to learn to use an app that you've downloaded from the App Store. And the truth is that these innovative workarounds are already in use. You know, it's sort of a taboo topic, but the vast majority of doctors and nurses today are using WhatsApp to communicate patient-identifiable data, to share images. And they do their best to keep it anonymized, but clearly there are risks to the current system. They don't comply with the most up-to-date NHS standards, and that's something that we've got to tackle. But frankly, we really can't blame clinicians. They're motivated to really make a difference, and they've committed their careers to helping patients to have the best possible care. Why wouldn't they take advantage of what they obviously see to be a tool that makes their lives easier? And I think the challenge for us is, how can we deploy some of the best user designers, some of the best engineers, some of the best machine learning researchers to work on some of the problems that really matter? So let's tackle the first patient safety challenge that Ara put to us. How do we identify which patients are at risk? So what's actually going wrong here? Why aren't we detecting them on time? Well, part of the problem is that we're not recognizing their physiological deterioration, and that creates a breakdown in reporting, and then we don't get access to the data in real time, largely because we're dependent on these sorts of hand-amended charts. They're really difficult to share, they're very difficult to interrogate. You only get information from them when you go to seek it, and that's an important dynamic. You only get information from them when you go to see it. It's exactly the opposite of the way that your smartphone works. Your smartphone tells you when there's an important piece of information that you might need to pay attention to. So let's take the example of acute kidney injury that we've been collaborating with the Royal Free on. Contributes to about 40,000 deaths annually. And quite remarkably, it's been estimated by NHS England that around 25% of these cases could be preventable. And this costs something on the order of £1 billion or so in direct NHS spending. It's a national priority, and in the last couple of years, the NHS have issued a patient safety alert to try to frame how clinicians respond to this. But essentially, this has been a PDF with the cutting-edge best practice emailed to everybody and stuck up on posters. And I think that that can be improved. So I'm going to tell you about a collaboration that we kicked off with Dr. Chris Lang and members of his team at the Royal Free over the last 6 or 7 months or so. Chris is a consultant nephrologist and kidney expert, and is also the associate medical director responsible for patient safety at the Free. So we set about co-designing directly hand-in-hand with clinicians at the Free. The first step is, how can we understand the user? Who is the user? What do they do? How do they work on a day-to-day basis? We did scores of focus groups and one-to-one interviews. We try to empathize with their day-to-day experience by shadowing them and trying to learn from what happens minute by minute, hour by hour during their day. And it was great fun for us. We use that to try and identify what their unmet needs are today. And we use those needs to then prioritize our own requirements, as you see here in some of the images. Immediately, as soon as we've got a sense of what their needs are, we start to build things. We prototype, we experiment, we sketch things, we do wireframes, and then immediately we want to test them. The answer is rinse and repeat. This process actually works. We go over it every 48 hours. As soon as we've heard that there's a new insight that somebody's had, we go and put it to wireframe, we sketch something out, and then we take it back to the nurses and doctors and we say, how does this look? Does this make sense? How would you like to change the buttons, the color, the choice architecture, the menu options? Does this flow make sense? We learn, we iterate, we test, and we constantly improve. The other component to our co-design has been to try and actually map out the complexity of this pathway. So it's been estimated there's something like 900 to 1,000 different patient-experienced pathways in the hospital system. So what does it look like for us to actually try and map this complexity out? Well, from the patient's perspective, it's pretty painful. Lots of different things are happening to this patient throughout the process. But if we zoom in a little bit, we can see that this red pathway here is where the vast majority of the activity takes place. And in some sense, this is when the patient has already developed some kind of life-threatening complication of AKI. So what we decided is, how can we go and look backwards? What happens before that part of the process? How can we do better risk assessment by looking at the underlying comorbidities? How can we do a better job of real-time monitoring of the data in order to try and proactively intervene in this patient's care in order to drive their experience down a parallel pathway that is more stable? So, obviously the best way to do this is to build something and test it. Here is the app that we co-designed with our colleagues and friends at the Royal Free. I'm going to run you through what it might look like. So we log in. Immediately, you see the patient list. And so this could be sorted by ward or by specialty or by consultant. And so if we go ahead and just tap on the first patient, we see that this patient actually has a pretty serious acute kidney injury level 3. We're able to browse through the results of the retrospective trend analysis, and we can see that there's been about a tripling against baseline of this person's creatinine. They're in a pretty bad way. And we also want to take a look at the potassium. We see that it's very highly raised at 7, so this could indicate a hyperkalemia. We may want to zoom in and take a look at the CRP, which is also extremely raised, and compare the trend analysis against our creatinine. Zooming out again, we see that lactate is at a 5.1, and this might give us an indication that this patient's cause of AKI has been a sepsis. If we want to see in a little bit more detail, we can see the retrospective blood test results, exactly who ordered it, when, what was the time, and what was the value in more detail. We can also zoom in and see a little bit more about the patient's details. You can see here that this patient has come in with type 2 diabetes and hypertension. And also, if we look down a little bit further, we see that they originally presented with abdominal pain and were subsequently diagnosed with acute appendicitis. We also have the contact details at hand so that we can contact both the next of kin and the general practitioner. So let me show you a little video now of
I think clinical teams like to be able to define problems and team up with people who can help solve them. It's been very interesting to have this collaboration between hospital and a company like DeepMind. We're very interested in the idea of streaming at speed clinical data to mobile platforms, because most of our teams spend a lot of their day on the move because they're doing their clinical jobs.
In my work, I'm quite involved in implementation science, which is a way of testing clinical changes in practice. Working with DeepMind Health has followed that model completely. That way of testing, iteratively testing, so planning something, doing it, studying whether we thought it was good or not, is extremely valuable.
What's nice about helping to design something is that we have a say in how it will be useful. What I've seen about the design of the app is that the screen is clean and it makes sense and there isn't too much information on it. It's not all in your face. Technology should support your work, should support what's going on with that patient. So if you can communicate that easily to people, it's going to save time and it's going to help you do your job and it's going to help you get to your patients quicker.
And so getting to your patients quicker is, of course, the part of detection which is only half the story. To respond to Ara's second patient safety challenge, the real question is, how do we actually manage the intervention once we've identified which patients we need to go and see at the bedside? And this is where I think the delivery of effective care has been delayed, according to Ara and Dominic and their research, in up to 50% of deteriorating patients. And their response was really quite incredible. They went off and created Hark to support nurses and doctors to deliver care much more effectively. Clinicians responded 37% faster with Hark than with pagers. And so tonight, I'm really proud to be able to announce that Hark's going to be joining forces with DeepMind Health and becoming an integral part of the service that we go on to provide. Let me take you through an example of what it might look like to manage tasks with Hark. So let's take the case of requesting a medication order. The patient clearly needs a prescription. The nurse goes on to bleep a doctor. The doctor hopefully calls back in good time. The doctor then will go to the ward and have a face-to-face conversation with the nurse, decide that yes, it's right that we need a prescription, and then go on and inform the nurse that the request has actually been completed, and then finally the patient is able to receive the medication. Of course, this assumes that you get through on the first bleep and that the poor nurse isn't just bleeping constantly because the doctor that he or she is trying to get hold of is actually on half-term this week or is busy in theatre all day. This is what should happen, really. Doctors should be able to prioritize and manage their tasks on their phone. They should be able to accept a task from a nurse and tick to say they're handling it. They should be able to have a conversation with a nurse or a fellow doctor in messaging in their app about that specific task, and then they should be able to send a confirmation message when it's been done, completely remotely, saving a vast amount of time. So this evening, I'm really pleased to be able to announce that we're going to be launching Streams by DeepMind Health. And our objective is, for the first time ever, I think, to integrate both the detection and task management into a single platform. The plan is for it to be a beautiful and intuitive and, most importantly, really easy to learn experience that anybody can download in the clinical setting and start using. Streams will deliver the right data to the right clinician at exactly the right time. And really the objective here is for us to try and shift some of the 97% or so of activity in the hospital today, which is reactive, further towards activity which is proactive and ultimately preventative. And this, of course, is where our cutting-edge analytics and machine learning comes in. How do you prioritize the series of alerts that go to a patient? How do you go to a doctor or a nurse? How do you identify which person on the clinical team should be receiving the right task? And how do you ensure that they've been followed up in good time? And of course, the real question here is ultimately how we'll be able to provide patients with access to this data. How will we be able to empower patients to play an active role in their own treatment and in their own experience, and really play a role in holding accountable the treatment that they receive whilst they're in hospital. So I really want to leave you with the idea that this time I think it's really important that we have to do things in a fundamentally different way. And for us, this is about partnering and co-designing with clinicians. Clinician-led technology is actually a new way of thinking about how we co-design interventions in the system. I truly believe that together we can revolutionize patient safety. And this evening I'd like to invite anybody and everybody who's interested to ping me an email personally and come and hang out in our office and come and talk to us about the apps that you have in your mind, the things that don't work for you, and your visions of how this might be able to work. Come and join our partnership. Thank you.